we're on a TV show or something.
We are.
We're live. Welcome everyone to the House Healthcare Committee. It is March 15th in the afternoon, and we are continuing our suicide prevention conversation. As we've kind of talked about since the beginning with this bill, again, just a reminder, we have H2 83 on the wall, but because it requires a lot of money and fees, it would have to go to money committees, and there's some things we're not going to be able to get done in the short amount of time that we have before crossover. So we've been hearing a lot of testimony in the hope that we will pass a committee bill that we can all agree upon, or at least majority can agree upon. Hopefully we all can. And part of H2 83 is what's called a suicide fatality review team. So we did pull that language from H2 83 for Katie to review with us, potentially to put into a committee bill. And if you remember yesterday with talking with Vermont Department of Health, they're doing a suicide data linkage project. So we've asked them to join us again today, because after I looked at the language last night and reflected back on the testimony yesterday, I think I want us to just talk more about what each would do and then determine what we want, if we want to move forward with this fatality review team. And then after we hear from everyone on this piece, we invited Terry Lafferty, hopefully I said that right, who's the American Foundation for Suicide Prevention in Vermont chapter. And she's she's been watching our testimony. She has a lot of experience in Vermont with suicide prevention. And so she's going to go back and touch on different things we've talked about over the last 2 days from a non-state agency perspective. And then we'll wrap up with a committee conversation. So that's our plan. So with that, I'm going to turn it over to Katie to walk through the language first, and then we'll go to testimony.
Perfect. Thank you. Katie McLean, Office of Legislative Counsel, just closed out of Zoom. I can't believe I just did that. So we can wait for me to pull the document up, or we can look at our own devices for your preferences.
But we can take a moment if you want to stay connected, because we should put it up.
Okay.
For everyone.
Take two. Okay. Success?
Great.
Okay. So as Representative Houghton said, this is a committee bill. And the purpose of this bill is to establish a suicide fatality review team. The language of this fatality review team is borrowed heavily from the child fatality review team and statute. It's in Title 33. So much of the language was in structure and the way documents are treated and managed were taken from that particular piece of statutory language and used here for the purposes of creating a suicide fatality review team. So in subsection A, this is the creation language. There is the suicide fatality review team within the Department of Mental Health for the following purposes: to examine cases of fatality in Vermont in which the fatality is known or suspected to be death by suicide. Second, to identify system gaps and risk factors associated with known or suspected deaths by suicide. Third, to release correlated findings based on social autopsies that identify opportunities for intervention. Fourth, to work with and inform organizations that can provide community supports based on identified opportunities for intervention. Fifth, to educate the public, service providers, and policymakers about death by suicide and suspected death by suicide, including strategies for intervention. And lastly, to recommend legislation, rules, policies, practices, training, and coordination of services that promote interagency collaboration and prevent future deaths by suicide. And then in subsection B, we go into the membership of this team, comprised of the following members: the Commissioner of Mental Health or designee, the Chief Medical Examiner or designee, a physician who specializes in the practice of psychiatry appointed by the Vermont Medical Society, a representative appointed by Vermont Care Partners, and lastly, a representative appointed by the Vermont Suicide Prevention Center. So 5 members of the team. And then we have language that members of the team appointed pursuant to subdivision C through E of the above list, so meaning the folks who are not state employees, shall serve 3-year terms. Members shall hold office for the term of their appointments and until their successors have been appointed. All vacancies shall be filled for the balance of the unexpired term in the same manner as the original appointment, and members are eligible for reappointment. And then we have guidance on what happens at the meetings. So first, in subdivision C1, the team shall meet at such times as may reasonably be necessary to carry out its duties, but at least once each calendar quarter. Second, the Commissioner of Mental Health or designee shall call the first meeting of the team to occur on or before September 30th of this year. The team shall select a chair and vice chair from among its members at the first meeting and annually thereafter. In terms of assistance, the team will have the administrative, technical, and legal assistance of the Department of Mental Health. With regard to access to information and records, subdivision E1, in any case under review by the team upon written request of the chair, a person who possesses information or records that are necessary and relevant to the review of a death by suicide or suspected death by suicide shall, as soon as practicable, provide the team with the information and records. All requests for information or records by the chair related to a case under review shall be provided by the person possessing the information or records to the team at no cost. A person shall not be held criminally or civilly liable for disclosing or providing information or records to the team pursuant to this subsection. The team shall not have access to the proceedings, reports, and records of a peer review committee. And then in subsection F, we cover limitations. The team's review process shall not commence until, first, any criminal prosecution arising out of the fatality is concluded, or the AG and the state's attorney provide written notice to the team that there are no criminal charges that will be filed. And second, any investigation by DCF. In subdivision F2, the team shall seek to obtain information or records generated in the course of an investigation from state agencies or law enforcement officials before making a request to healthcare providers and educators. And we have language about confidentiality. The records produced or acquired by the team are exempt from public inspection and copying under the Public Records Act and shall be kept confidential. The records of the team are not subject to subpoena, discovery, or introduction into evidence in a civil or criminal action. Nothing in this section shall be construed to limit or restrict the right to discover or use in any civil or criminal proceedings, information, or records that are available from another source and entirely outside the team's review. The team shall not use the information or records generated during the course of its review for purpose other than those described in this section. So it has to be for work related to the fatality review team. In subsection B, the department may share de-identified data produced or acquired by the team with other states that have suicide fatality review panels, provided that access under such agreements is consistent with the privacy, security, and disclosure protections that are provided for in this chapter. And then we have subdivision 2, the team's meetings are confidential and are exempt from the open meeting law. Members of the team and persons invited to testify before the team are not to disclose information, records, discussions, and opinions stated in connection to the team's review. Members of the team and persons invited to testify before the team shall execute a sworn statement honoring the confidentiality of all information, records, discussions, and opinions related to the team's review, which shall be maintained by the chair. And then we have a reporting requirement in subsection H. Notwithstanding 2 VSA 20D, that's the language that a report has to be reviewed every, I want to say 5 years, to see if the committee still wants that report to come. So that's notwithstood. The team shall report its conclusions and recommendations to the Governor and General Assembly as the team deems necessary, but not less frequently than once per calendar year. So what this language doesn't say is when to expect the report. So when we go through our reports at the beginning of the year, we couldn't anticipate that this is coming February 1st. The report shall disclose individually identifiable information only to the extent necessary to convey the team's conclusions and recommendations, and any such disclosure shall be limited to information already known to the public. The report shall be available to the public through the Department of Mental Health. And that is it.
So I have one question, back on, there was a reference to Department of Children and Families. And I'm wondering if that's, is that appropriate? Should it be Department of Mental Health here, or should it be Department of Children and Families?
Is it a carryover from?
Right.
Do you mean the review? I'm sorry to jump in, but do you mean the part where it says the team's review process shall not commence until any investigation by the Department for Children? Is this for Children and Families is concluded? Is that what you're referring to?
Line 8.
Yes.
Yeah.
Page 1,
Line
page 4.
8, page 4.
So not anything we have to discuss right now. I just want to flag that.
Yeah, I have an argument both ways, but I think probably it's a carryover. So let me think that.
Okay. And we're going to hear from a couple people before we go real deep into this language. Okay.
Yeah, and maybe I'll put my concerns or questions out there because then the witnesses can weigh in on them proactively. Like that, I'm curious what would be some examples of criminal prosecution that might come out of a fatality like this. I'm curious how many reviews would be done in a year and what that workload would look like, considering that we created a mental health crisis commission to look into police death, like deaths of people in mental health crisis by police. And like, it took a very long time for them to investigate one case, and they didn't go through every single one. So these are just some questions about like, what is.
So I think I'm going to hold off on you continue, but those are great questions because let's just worry about the language. Let's just like take in what we're seeing. Well, if it's about the language, I'll let you go. And then let's hear from the folks who run the child fatality review team and then have thoughts about this as well. So
I just wanted to flag also, speaking of the child fatality review team, that should we have a section in here that it exempts suicides under 18 and that information should be then obtained from the child fatality because that would be duplicate work.
yes, that would be duplicate work. So let's throw that out for the witnesses.
Is there going to be money attached to this?
So the money attached to this, is there per diem information in here?
No.
So no, right now, no. Leslie?
Two questions, if I may. Is this considered quasi judicial? Because you have to take an oath. How does that work?
I don't have a great answer to that question. I mean, they're not making a determination of somebody's responsibility for a particular action. I would say it's sort of outside of that context because the context is how do we put systems in place that better support people before a suicide happens. So I would say it's not really.
You're not concluding anything, but you do have to take an oath to be confidential, right? Is that what I'm understanding? That somewhere in there at the end it says sworn.
Yeah, that might be a great question for the child fatality review team, how they manage that because it's the same language as their statute.
Okay. And my other question is a social autopsy a thing? I mean,
Let's save that for them
too. Okay,
Yep. All right, thank you, Katie. So you can take down the language because I want to make sure we can see people. And I first want to recognize that Nick Nichols from Department of Mental Health is back with us. So is Caitlin Quinn. And I did not originally include them because I did not realize that the child fatality review team fell under VDH. So they graciously are here and I only invited them this morning. So thank you both for that. I appreciate it. And then Becca Bell is here, and she, from my understanding, is on the child fatality review team, and is having issues connecting to. So are you good? Okay. So what I think I want to do, if it's okay, is start with Nick or Caitlin. Just a couple minutes of what the child fatality review team is and how it works. Could you speak to that?
So, hello everyone. Nick Nichols from the Vermont Department of Health. I'm the Suicide Prevention Care Coordinator. Caitlin and I actually, there may have been some wires crossed, but we were under the impression we're coming here to talk about the data linkage projects. And so I might suggest if you have questions about the Child Fatality Review team, maybe start with Dr. Bell, because neither myself nor Caitlin serve on that team.
Perfect.
So we probably wouldn't be the best folks to answer those questions.
Okay, so I'm going to start with Dr. Bell. If she's able to, or she's in the middle of something, we will come back to her.
I'm not. I'm using my phone.
Oh,
Okay, yeah. I'm using this old tech, like, can you even recognize what this thing is?
It's an actual phone.
It's like, what is that thing on our ear? I was prepping for this testimony by, like, I restarted my computer because it's been slow at work, and then the speakers wouldn't work. So I thought best laid plans, right? But this hopefully is working okay. So I'm Becca Bell. I'm a pediatric intensivist at UVM Children's Hospital. I'm really here speaking on behalf of Vermont Medical Society and AAP Vermont, but I am also a member of the Child Fatality Review team. I am not a leader, though, of that team. I'm not one of the co-chairs. So I can talk a little bit about what I know, but we may have to, and I am happy to be the facilitator to answer questions if some of the questions need to go to the co-chairs about process. So first of all, I think it's a great team. It's a multidisciplinary team. It's really under VDH, specifically within the Office of the Medical Examiner. So the medical examiner, Dr. Elizabeth Bundock was the chair for a long time, and her team actually initially gathers the data for us, and then the team is made up, I mean, you can see in the statute, of a number of different professionals. So I'm on there representing pediatrics. There's a child abuse pediatrician, psychiatrist, psychologist, DCF, school representation, Howard Center. I'm sure I'm missing a lot of people. Of course, the health department, many members of the health department, the state's attorney's office. So a great team, all really focused on kids and family centric, because a child death never happens in isolation. So the Office of the Medical Examiner picks the case, finds the cases that they determine to be unexpected. So there's a little bit of subjectivity there, but the idea behind it is that we would review all unexpected pediatric deaths, so under the age of 18, 17 years old and below. And typically we're all given, so we do take an oath. I think somebody said that this is very confidential. But within our fields, we do have the ability, because this is in statute, to request information. So for my part, I can request medical information from medical providers. We have that covered. Law enforcement will submit their reports. OME will submit their report. DCF will submit their report. And so we basically get the list of names a couple of weeks ahead of time, and then we compile our information from our area of expertise and send them all to the Office of the Medical Examiner team. That puts us all together, and then we meet and sort of go through these cases in detail and have a discussion, and sometimes we require follow-up. Sort of depends on where the cases take us. It is a lot of work. It is very insight, it provides a lot of insight and a lot of more information than you would get otherwise, and I find it really, really, really useful. It is a ton of work, though. So I agree. From Representative Black had mentioned that we have a process for reviewing all of the pediatric or the child suicide deaths. So we would like to continue to do that, because there's, we've got schools involved and DCF and family stuff that we kind of circle back around. But we can either report out to the Suicide Fatality Review team once or twice a year. Or the other thing that we've done before, because there's a domestic violence fatality review team, for instance, is that we can also invite members of the suicide fatality review team to our review. So we usually batch the reviews based on theme. So we might have 1 month where we're looking at drownings, 1 month when we're looking at infant sleep-related deaths, 1 month we're looking at suicide. So we couldn't also just have them be incorporated into part of the process. So that was in my testimony, just added that we would like to, the child fatality, I think, has a really good system for how we review, and it would be great to continue to be the first to sort of initiate and review that process, and then work really collaboratively with the suicide fatality review team. And then the only other piece is just looking at the list. I do think it would be helpful, and VMS is happy to help appoint a psychiatrist, but I think primary care and just thinking about community folks, because a lot of these, as we know, some of these folks are really involved in the mental health system, but many are not. Many of our suicide deaths in the state are not. And so including people who are community providers. And for VMS's standpoint, that would be a primary care physician, and there may be opportunities for other types of community providers that might be helpful to have on this team as they go through the review.
Great.
I'll sort of stop there and see what questions you have.
Great, thank you. I have a couple questions. So if we do this, and obviously we keep at your request, because it seems like there's a system that's working, that the youth suicides are kept within the child fatality team. So first, my question is, are all youth suicides reviewed, or is it does the medical examiner pick?
My understanding is that they're all reviewed, and we also, really the idea is that all unexpected child deaths are reviewed. Okay. So my understanding is, and sometimes we have cases where it's undetermined really what the intent was around the death, and we review those cases as well. So yes, I believe that we are reviewing all of them.
So in a suicide fatality review team, the focus would be on those 19 and older. So from your understanding of what you've done, obviously around suicide prevention in the state, and then your work on the child fatality review team, can you tell us what your opinion or the VMS opinion is on establishing this for the 19 and olders, and if you think it would be a benefit to help us really determine where system gaps are and things we should be doing as a state?
Yeah, I think it's a great idea. I think we've all learned a lot through the child fatality review team and have been able to get some insight around some of the deaths that are occurring. So we're supportive. VMS is supportive of such a team. I will just clarify, it would be 18 and above. 18 and above. We do under 18. So it would be 18 years and above, and we're supportive of the idea. I do want to say that it would be a lot of cases to review. Right. That the team would be reviewing about 100 cases a year, right? So, or more. So it is a lot, but I think just like Nick and Caitlin have been, and I work with both of them, like just trying to understand the data. There's like the superficial data that we can kind of gather, but there's something else to really being able to dig a little bit deeper and understand some of what's going on, and some of it's sort of surprising. So I'm supportive of the idea. I just want to put out there that it requires resources and time and expertise. That's all.
Thank you. Topper, and then Alyssa.
Does anybody, I have a question about who makes the decision that a death is a suicide? Who makes that decision? And let me give you an example. Somebody doesn't wake up in the morning.
Yeah, so that's the Office of the Medical Examiner. So whenever there's unexplained death, the medical examiner gets involved in that case, whether it's a child or an adult, and so they do an autopsy and then they make a report. But that would be something you may want to actually talk to the medical examiner's office about. But this kind of thing is and I'm not a pathologist, so I can't really speak to it, but there are protocols in what you're going to do for like an unexpected or unexplained death in terms of testing that you do, an autopsy, and then what the death certificate ultimately says. But an example that you just gave without any evidence of any self-inflicted injury or other evidence, that would be a maybe an undetermined death or something like that. And so the death certificate will usually also have like potential contributing known or potential contributing factors, environmental factors, medical factors, that sort of thing. So there is a process, but I'm definitely not the expert in that.
Thank you.
I was just wondering if you were able to answer Leslie's question on what a social autopsy is.
Yes, I think Caitlin might know a bit about that too. So I might actually send that over to Caitlin, but that too is a way to sort of look to do sort of what we're trying to do. And again, like the Suicide Data Linkage Project, which is to just get more information about the other details around the patient, but I would actually have to kick that over to Caitlin to answer.
Okay, so Caitlin, I'm going to hold for 1 second on that because I know Dr. Bell has stopped, so I want to get all our questions for her. Dr. Bell, do you have knowledge of the Suicide Data Linkage Program?
Yep.
So one of the reasons I wanted VDH to come back in, so I'm going to ask them the same question too. But based on what we're trying to achieve through the purposes listed in the legislation, and knowing that the Suicide Data Linkage Program is going to be looking back for 2 years, do you think we should be implementing the suicide fatality at this time? Because will the Suicide Data Linkage Program be giving us what we need to figure out gaps in our system and how to move forward with suicide prevention? Or do you think it's still needed? Broad question.
That's a great question, and I feel as though that they're both are trying to accomplish the same goals. So I agree that the idea behind it is to not necessarily, it's really about identifying gaps in systems and also identifying, root causes and other things to really understand what's going on. So I do feel that the Linkage Project is trying to accomplish that same thing. So I think either way, I'm sorry, I feel like I'm not, I don't know as much about the Linkage Project as Nick and Caitlin. And Caitlin, I will just add, has come to our child fatality review to help us with data and has helped with our reports. And I think she would also be a great person to weigh in here on sort of the difference in what she's looking at. So I do think like the goal is the same.
Okay. So Dr. Bell, could you hang for 10 minutes while we let Caitlin answer a couple of questions? Yep. And okay, that would be great. So Caitlin or Nick, I'm going to go to both of you. And I guess first, the broad question of what is a social autopsy?
So once again, this is Nick Nichols from the Department of Health. So social autopsy, at least the way that it's been used here in Vermont, is a different version or a very similar project to what the Data Linkage Project is that we're going to be sharing. So it might make sense for us to talk more about the Data Linkage Project, because the origin was there was a Vermont social autopsy project focused on overdose deaths in Vermont, and we actually modeled the Data Linkage Project after that work. And so we can talk about how, social autopsy basically is the idea of looking at collecting as much data and information about the circumstances around someone's death to understand what they were going through and what happened to them. And there's sort of different versions of autopsies, but social autopsies. But the one that's sort of occurred more recently in Vermont was around overdose deaths. And like I said, it's very similar to the Data Linkage Project that we'll be implementing.
Okay. So you've seen the language on the suicide fatality and the purposes there, and obviously you know what you're doing in the suicide data linkage project. So can you or Caitlin kind of explain to us how they may overlap or may not overlap?
Yeah, so today I think what would the best we could probably do is just give you more information about what's going to be collected through the data linkage projects, and you can compare that with what is being proposed through the suicide the fatality review team. We have not prepared enough to really comment on specifically the creation of the suicide fatality review team, but can give you as much information as you want about the data linkage project.
Great.
So do you want us to go ahead and do our
yes, that'd be great.
So
you know what, before you start, I don't want to keep Dr. Bell. So Dr. Bell, feel free to drop at any time and we will reach out if we have questions. I know you're busy and don't want to keep you. So sorry, Nick, go ahead.
Yeah.
Great. And if I could have permission to share my screen, we do have a short PowerPoint presentation, if that's okay.
He's working on it.
Should be set up.
You should be set.
Great. Can folks see that okay?
Yes.
Now we can.
Great. So once again, for the record, Nick Nichols, I am the Suicide Prevention Program Coordinator at the Vermont Department of Health. I oversee a federal grant that we have at the Department of Health implementing various suicide prevention strategies using a public health approach, and it's from the Centers for Disease Control and Prevention. And we're here today just to talk about, give you some additional information on top of what we shared yesterday about a new data analysis project underway at the Department of Health called the Data Linkage Project. And so today we'll be providing an overview of the project. We'll be sharing some examples of the information that we'll be collecting, that will be collected. And then we're also going to talk a little bit about how Vermont could use data from that project. And so I'll start and give a little bit of background, and then Caitlin's going to go into more detail in terms of the specific content that's going to be created. So in terms of background, you know, Vermont already collects a significant amount of data about suicide deaths in Vermont, but through our grant from the CDC, we're allowed to put funding towards improving both the information that we collect, as well as how we analyze that data and how we use it to improve suicide prevention programming. And so after receiving the CDC grant, we started to look at what are the different ways that we could improve our use of data. And we decided to replicate a data linkage project, which was known as a social autopsy project that was implemented back in 2019 and 2020, focusing on overdose deaths. And some of you actually may have seen the report from this project. It's called the Vermont Social Autopsy Report for Overdose Deaths. And we can send you a link to that report. It's going to be coming out on a regular basis, but it'll give you a good sense of the information that comes out of these kinds of social autopsy data linkage projects and what you can do with that. And through that project, VDH was hoping to better understand how and when individuals were interacting with various programs and systems and services here in Vermont prior to their death via overdose. And the Department of Health was also aware that when you looked across the various programs and systems throughout Vermont, there's actually a lot of data that already exists, but it just sits in different silos. And so if we could actually pull data from those various silos and those various data sets, we could actually learn a lot more about what's happening to people prior to their death, and then use that information to improve how we work with those programs to implement prevention efforts. And I won't get into a lot of detail about that specific report, but just one example of how it was used is that through that report, the Department of Health was able to pull data from the Department of Public Safety. And through the pulling of that data, they were able to determine that a very high number of individuals who were dying by overdose had recent interactions with law enforcement prior to their death. And so based on that data, VDH started to work with law enforcement, and they created a Leave Behind program, which ensures that law enforcement officers have ready access to Narcan. and are able to distribute it appropriately to people who may be at risk for overdose. And it's also resulted in more training for law enforcement to reduce stigma and empower law enforcement to take a more active role in supporting people who are struggling with suicide issues. And so based on the success of that program, we felt like it made sense for us to use a similar process to pull from all these various data sets and look at, of the people who are dying by suicide, what can we learn or what do we know about the various systems and programs that they're interacting with prior to their death, and also just try and better understand what was going on in their life. So for example, were they having legal issues? Were they housing insecure? Were they having specific medical issues? Were they seeking out different types of supports? Are there specific programs that we're not currently working with, but that are seeing a high number of these people? And so based on the information that we collect from this project, it's going to allow us to better identify the places and programs and circumstances where we should be prioritizing our resources and doing a better job of finding people who may be struggling, but not able to access the right kind of support. And so with that, I will turn things over to Caitlin. And Caitlin's going to provide some additional detail about the specific data that's going to be collected through the project.
Great.
Yeah. Good afternoon, everyone. Thank you so much again for inviting me back here today. I'm so excited to speak with you all about a project that is very near and dear to my heart. I think Nick did a really fantastic job summarizing the project, but I'll just kind of provide some of the technical details that you all may or may not be interested in. But the overall goal of this project is to really understand both the risk factors and interactions people had before they died by suicide. This data analysis project will use suicide deaths that occurred in 2020 and 2021, and we will be linking this data to various databases. The data will be looked at systematically to assess both the risk factors and interactions. And when I say we're looking at the data systematically, the type of data that would be included in a report would be something like, X% of suicide deaths experienced this risk factor or had this interaction before they passed away. I also want to call out that this project, really was accomplished through partnering with several state agencies and organizations, both internal and external to state government. This project is super collaborative in the sense that all of the indicators and data and objectives of the project were really developed through, meeting with stakeholders and having meetings to discussing, what's important to know about people who've died by suicide and how are you going to be using this information. In terms of the why or the rationale for doing this project, I think Nick did a fantastic job detailing that. But again, it's to help identify gaps in the suicide prevention work that we're doing and help us in identifying individuals who may benefit from more suicide prevention programming support. Next slide, please. So now I'm going to share with you probably the two biggest things that I'm most excited for with this project, and that's understanding the interactions people had within a year of death. So this first slide shows the different types of healthcare related interactions that we're going to be looking at. This data will be coming from medical billing claims data, so whether someone had insurance, they would be reflected in this data set. And then also if someone had an interaction with EMS. So these are the types of visits or encounters that we're going to be looking at. We're going to be looking at the timing of the encounter, and we're really going to be focusing on interactions within a year of death. And the reason for that is to help us identify whether there are certain types of encounters that are happening close to the individual's passings, and could tell us where we could be doing more suicide prevention work. Next slide, please. And then we'll also be looking at a myriad of other interactions. Again, most of these interactions are going to just be examined within a year of death. Some of these interactions we will have in another part of the report that just looks at, whether someone had ever had a history of being incarcerated in Vermont. So some of the types of interactions that we're going to be looking at include being incarcerated or serving on parole, whether someone had an interaction with law enforcement, whether someone was involved with the court system, whether someone was receiving a service related to a disability, whether they had evidence of employment, whether they were receiving mental health services involved with the Department of Children and Families. And then we're also going to be looking at whether someone was receiving a service for experiencing homelessness. So those are, I think, the highlights of the project. We also have like 6 or 5 other objectives and with data that we'll be looking at, but I'm happy to answer any questions. And we're really excited to be putting this report together now.
Great, thank you. That was very, why are we echoing? That was very helpful. Sorry, we were echoing. So questions, Alyssa?
I'm just curious I understand the project, and, the ability to identify these interactions within, certain departments or settings, and being able to then, use that as kind of an intervention, like just talking about primary care visits, because I think we've heard a lot in previous testimony that most people have had a visit with their primary care and sort of using the assessment. But what else are we identifying if people have had no interactions? I mean, it seems like we're, well, just from the presentation that you've given, are we just looking for those that have already had some sort of interaction and where we can intervene in that case? Or are we looking at the people that have had no interactions?
Yeah, that's a great question, Representative Black, and I think it's both. I think, in addition to our healthcare data, there's a lot of information just about things like employment or legal issues, housing, sort of different kinds of support services. And so in addition to the sort of the healthcare system, we're hoping to find other places that people are appearing. For instance, are we seeing that a lot of people who are experiencing this type of legal issue we've got higher rates, or they're higher, more at risk? And so do we need to set up ways to intervene with or check with people who are in that particular situation? And at the same time, if we find that there are a lot of people who had no interactions with any of these systems, that's actually going to be really helpful information too, because it'll tell us we need to find other ways to reach them or to connect them. And that by putting in screening or educational programming with these various programs is going to miss some of these individuals. And so that might tell us we need to do more of a public health sort of media process where we're using Google and TikTok or whatever to reach people who maybe are in a certain age group and like to research hunting or whatever. So there's going to be a lot of other information that we get when we look at people who don't appear on any of these, but it will be helpful information so we can have a better sense. And I kind of go back to that stat that I said yesterday, and that we do know that the majority of people who die by suicide in Vermont were not actively engaged in mental health treatment at the time of their death. And so we know we're missing people for whatever reason. They've either tried to access mental health or they were not able to access mental health. And so we need to find ways to find those people and provide them the right kind of support. And this is kind of another way to figure out where else could they be and how else can we find them? And it's a great question.
Can I ask you? Mm-hmm. And also, because I've read all the reports from the Child Fatality Review Team. Every year, they make a recommendation around safe storage. Are you calling data on methods and opportunities for policy Is that also information that you're pulling, or are you really just looking at, like I said, interactions within the systems that are currently in existence?
Caitlin, do you want to start with that one, or do you want me to? Because we've definitely talked about that.
Yes. So in one of our sections of the report that looks at risk factors among those who have died, we will have like a subsection on the means that was used in death, and then also whether or not the individual was experiencing a crisis. So we will have some data on the means. Also, I will add that with this report, it will be data, and then there will be recommendations based off of the data. So that may or may not be related to, the interactions or other risk factors. Does that make sense?
I think so.
Art, and then Brian.
Yeah, I'm wondering, and I may have missed it in all of this, what type of personal data we collect or is collected that might paint a picture of suicide in the state. In other words, do we get basics like age, gender, race, location where they live, occupation, church affiliation, if there is any of those things that could point to, and I would love to see all that on a map of the state, just to get a sense of what we're looking at here, so that we can, is that, and what school for children, what school are they going to? And I wonder how that plays into all this, if it does.
The death certificate collects some of the demographic data that you were speaking to, such as age, gender, location, town of residence, race, ethnicity, education, marital status, industry, occupation, those sorts of things. We have data reports that show, some of the demographics that are at risk for suicide. Where in the state do we see higher rates of suicide? All of that data is published on our website and something that we update annually.
Okay, so you do have that information and you put it out. Okay, thank you. Yeah. Thank you.
Brian.
Yeah, I wanted to look more closely at the presentation. I don't see anything posted yet. Is it something that I missed, or can you send?
Not there yet.
Okay. Because I want to just read a little more. I don't want to ask questions if it's in it. And when it was on the screen, or maybe we could put it back up on the screen briefly. I just couldn't read it quickly enough because I had my glasses off, and then when I put them on. Yeah.
There's just so much text. I apologize for that.
Oh, it's okay. I just want to read it more carefully before I ask dumb questions. It's actually, if you can go ahead to where you were, I want to just look at this. I wanted to look at all the different engagements with systems of government that people are having, and that's what and I just wanted to clarify that that's what it looks like, is it's engagements with systems of government. I guess my question is there a way to look at engagements with community broader than government? And I don't know how we do that, but that might be, because if someone hasn't engaged with the government, it could be a sign that people feel like they don't trust government, or government's not accessible, but they might have sought help in the community. And if that failed them, then we need to find out why, and maybe either, increase community supports, or I don't know. So if there's a way, but I want to read this more carefully before I put that out there and just be clear, like these are all, I think this is all great though. So. Yeah.
So my question to you would be like, what community services are you interested in? Like a lot of what we've heard from partners is really like healthcare-y types of interactions. So we have the ability to collect that information. We also are going to be collecting data, or we have data from people that were experiencing homelessness or housing instability, or people who were using AAA, or the area's agency on agency, so receiving things like Meals on Wheels, or calling the helpline. So those sorts of programs. And then I tried a few other community organizations and didn't have much luck. But yeah, if you think of certain specific community organizations that you're interested in, I'd be happy in telling you if we partner with them or have reached them.
I could throw a few out there right now, and they might fit through, like, some of them might get funding through one of these systems, and you might touch on it, but I'm thinking like the at-risk groups, like veterans, maybe talking to the VA, but also maybe talking to VFWs and like veterans clubs and for like LGBTQ plus people, like the Pride Center or Safe Space or like Outright, but then also like if we find out like a person was part of a social group, maybe is reaching out and just saying like, you don't have to cooperate, but if you want to talk about your friend's death, we're trying to learn, how to make it better for others. People might be willing to talk and say, we were trying to help them and here were the barriers, or they might say they never asked. And religious groups, I think people go to their ministers or their, priests or for advice, and like, maybe we can't compel people, but like inviting them to participate. And then in general, like, I'm just thinking like, we heard like, like, I don't know if older white men is fair to say, but like, grown white men or whatever, not kids, adult white men in rural areas. Maybe if we find out someone died by gun, a firearm, and they were part of a gun club, I don't know, just talking with their buddies and being like, did you have any warning signs? Did you, and maybe they would say no, or maybe they would say, yeah, we didn't know what to do. I don't know. I'm just thinking like there might be some like non-government things.
Definitely. Yeah. And that sounds like, a little bit of qualitative data would really come out of some of the things that you're speaking to, which I think is, something we can look into in the future. Yeah, I would say for this iteration of the project, all of these databases like currently exist and are easily matchable, or we're able to match the death data to these databases. So it's the simplest way to do this project. But future iterations could do some of the deeper dives that you speak to.
Caitlin, I'm going to go to Leslie. I'm sorry, go ahead, Nick.
Oh, I'm all set. I think that my computer just glitched.
Oh, okay. So we have a couple more questions. I just want to ask one real quick. Caitlin, what is the timeline here? Or Nick, either one.
The timeline, so we are planning to publish the report on Suicide Prevention Day, which is September, Nick, 17th, 12th, 13th? Google?
One of those days, that's fine. September 23, right? Caitlin, this September?
Yes, September 2023, sorry.
Okay. Leslie?
Yeah, thank you. Thank you for that, Caitlin. I'm just thinking also about what Brian's talking about when we talk about a social autopsy, that goes beyond that notion of the state agencies or, those contacts. And so thinking socially beyond that, I think would be really helpful. Because as I've been told, not some things are impulsive and, and I just don't know how you fit that into your project, but I think it's important to look beyond that list, I guess. And I just want to support those ideas that Brian just put forth and trying to really understand the forces behind what's going on.
Yes.
Dr. Bell, are you still on? I mean, I see you're on, but are you still there? Ah, she is. Quick question for you. I don't know if you heard Brian was talking about more of the community-based type of data. Does the child fatality review team look at that information or try to gather that type of data? Is that happening today with your reviews?
So we have someone who reaches out to the school and talks with the school leaders. We have, if the family was involved in DCF, we have access to all those reports. And so that's it's mostly school, DCF, family. Oftentimes, I mean, we are reviewing these cases many months later, 6 months later, maybe even a year later, right? So we'll do follow-up with oftentimes are other siblings, right? So we check in with the pediatrician to see how the family's doing and the siblings are doing. And then there's often, as folks have talked about, postvention services. And so some of the folks involved in that postvention work are part of the team. So like Howard Center. So they may have had continued contact with the family to sort of give an update. So part of what we do is just sort of getting a sense of how the family's doing afterwards and the community's doing afterwards. And then I would just add that part of what we do is we have law enforcement reports that we review as part of this, and that is also really informative because, EMS reports and law enforcement, and then, the method and the means really matter, as I know you've heard me all say, and so understanding like what was the method used and how was it obtained and what lengths anybody had gone to try to limit some of the access to that is going to be a really important piece of this, just because, again, as we know, there's the most common method here in Vermont is firearms. So just understanding a bit more about that, because that, like to Nick's point, and many cases we review there's no mental health history. There's a really, really impulsive act in access to firearms. So in that case, the approach is different to address those kinds of deaths than some of the other types of deaths. And I think we're all realizing this as we go through this work, is that we can't, and this is why this data linkage project is so important and case review is so important, because it's not like you can average out and say like this many people die from suicide, like on average have this problem. It's like it's really different populations of people and their risk factors are different, and the approaches to help them are going to be really different. Some it's going to be through mental health, some it's going to be through access to firearms. So anyway, just understanding this and getting more and more data is really helpful so we can sort of parse out the populations at risk here.
Okay, great, thank you. So we have Art, and then Alyssa, and then Brian.
Yes, and you probably don't know the percentage off the top of your head, but I'm wondering how many over time suicide deaths you've investigated that fall outside the parameters you've shown and just leave you scratching your head. There is nothing. There doesn't seem to be an issue. There doesn't, and I'm just grasping for, what would you say the percentage that you don't fit into any of these things are? Any idea? I have a follow-up too.
If this is for me, I mean, I'm only looking at pediatric deaths, which is different than the whole population of Vermont. It's a smaller population. I would say most of the pediatric suicide deaths are impulsive. They're like very, very impulsive. No one had any idea. I also take care of lots of young people who attempt suicide, who end up in our ICU, end up in our hospital. So I do care for, and so I understand there are different populations, the people who are in the ER a lot, the people who are sometimes in the ICU after an attempt, tend to be, not always, but tend to be different than the kids that are dying, there are other risk factors we found in the literature too around like impulsive acts, like someone who acts out impulsively. That's more of a risk factor for like a firearm suicide death, for instance, than someone who has like a history of depression among young people. So understanding that is really helpful. And for me, my clinical work and then the fatality review helps in both of those help inform each other, so I can sort of understand that it's just not going to be a one size fits all. I think the reason I will just share with the committee, I mean, the reason why I'm passionate about this issue, honestly, is because of exactly those cases you just mentioned. It's the scratching your head, like those cases, because they're really devastating for families and communities, and it does seem like something that we need to raise awareness about and then and intervene on in a way that might be different than people expect. So for kids, I would say about half are like really. There's
How
really
about for
very
adults?
unexpected.
What do you think for
Okay,
adults?
yeah.
I think I was thinking more of adults in that vein, maybe.
I would have to ask Caitlin and Nick, because I think they would know that better.
Thank you.
Yeah, it's a great question, and I have not seen sort of a thorough deep dive analysis in exactly answering that question. I would say that everything that I've looked at, the majority of people, when you talk to their families and friends or extended network, there's always indicators that something was going on in their life that was causing them despair or lack of hope. And they also had, access to lethal means. And, there are certain risk and protective factors that have been shown to really contribute to the likelihood that someone is going to attempt or die by suicide. And so I would say there's probably very few individuals who where you wouldn't be able to find some of those risk factors in place or lack of protective factors that led them down that path. And for some people, they struggle with thoughts of suicide for their entire life. They may have started experiencing it when they were 12 and, until the day they die, but they figure out ways to manage it. And for other people, it can be a very impulsive, very unexpected thing. But that's sort of why it's so important to educate the public as much as possible so we all are more aware and understand like when people might be experiencing some of those issues or acting in a way that's different. That makes you just say, I'm worried about this person. And rather than just be quiet, I'm going to ask them like, hey, are you doing okay? Are you having thoughts of suicide? That's sort of why it's important for us to take this approach, because there are a lot of people who are missing and we're failing to see the signs. And it can be very hard. And there are times when people say, you know what, people tried really hard, but everyone dismissed this and no one's at fault. But we clearly as a state can do much better to be more equipped and aware to catch people who may be struggling.
Do you look at the family background or heredity in this at all? Is that ever about
Heredity, is that what you said?
heredity?
Okay.
So there are.
I don't know. I throw it out there. I don't want to stump you here at all. I just want.
Yeah, we can share some resource documents that provide sort of various risk factors, and some of them are sort of biologically based or more have to do with sort of physical makeup. So we can share those with you.
Thanks, Nick. So I want to go to you have a question?
It's a strange question, but yes.
Okay, hold on. So I want to go to Alyssa and then Brian and then Bobby, and then we are going to have to stop because I want to go to Terry. I want to make sure we have time for Terry. So Alyssa.
I think I'm just going to ask a really obvious question to Brian's point and Leslie's point, and also my question. Do you think that there is a difference in having an independent legislative review team collect data as opposed to within the administration? Do you think the questions are different? And do you think the recommendations would be different? For anyone who'd like to answer.
So, and I apologize for not knowing, but is the proposed suicide fatality review team proposed to be an independent entity outside of state government?
Well, no, because it would be very similar to the suicide fatality child fatality review board, which I believe has state representatives and it's my understanding it's co-managed by VDH and DMH.
So if I correct me if I'm wrong. So the question is sort of, is there, and I apologize if I'm not paraphrasing this correctly, but is there value or difference in having a review team like this sit outside of state government and be independent?
Yes, or a legislated review team as opposed to a grant driven with inside the administration.
I don't know if I'm prepared to speak to that today, but I would just say the more people you can have looking at an issue and analyzing it and providing different perspectives, I think the better. You're more likely to come up with a creative set conclusions and recommendations. So.
Thank you, Brian.
Yeah, so I have two kind of questions that are really different. One is, we were talking about community, people to talk with in the community, and I'm just wondering what the possibility might be to, if somebody dies by suicide using a firearm, to determine where they got it and if it was recent, to actually talk with the seller about what happened. And then that makes me think too, back to an idea we had talked about of educating sellers of guns in the warning signs. Because the other day I was in a store and I saw this man purchasing, I just checked, it was an air gun, right? Because I was like, I didn't know if he was buying like a real gun or not, but he was pressuring the clerk. And the clerk was like clearly nervous selling this to the guy. And I watched that and I was like hiding in the, like spying, like just like observing it. And I was like, this clerk is some young kid who's scared right now to sell this man this, luckily pellet gun. And the guy was pressuring, like rushing him. And so I saw that and I'm like, it just goes to like, are people adequately prepared when they're selling a weapon to address warning signs if they see them, not even just look for them, but like if there's anything concerning, what do they do? And I don't know if that's your job to answer, but like maybe you could, a start would be just talking with them about what they see, you know, in those situations and learning. And then that might help guide us in like how we can support them. So I don't know if that's an idea that you tried. So that's kind of like a yes or no, or how would that work? Let me ask the other question and then you can choose how to answer. It's a numbers question. How many cases per year, and it might be different every year, has the child fatality review team?
We lost Dr. Bell, so I don't think you're going to get that even here.
And then I guess I wanted to compare that to like, I can look this up myself,
Right.
but like looking at what the last few years of suicide deaths were, and just seeing like, you know, for example, if the child fatality review team is handling 20 a year, but we have 150, we're not going to be able to do 150. So, I mean, that's something we should look at. And if you don't know the number now, it's okay, but I'm curious I can look up, I'll do the labor to look up suicide deaths.
Suicides a year is 120.
That's what the latest was?
The average number was
Average, okay.
And it's in there.
124, 125.
It's in there somewhere. It's in some of us.
I could answer his question.
Okay, go
There
ahead.
were 5 cases reviewed by the child fatality review team in the last year, in 22.
And so it's even more of a stark difference. Like, you know, how are we going to get to 120? So we might need they might need to triage or prioritize, or I don't know. We don't have to solve it today, but it's what comes to mind. Like, because I respect the work you're doing, and I know the Mental Health Crisis Commission did thorough work, and it took like a long time to investigate one. So I just want to be realistic about what we're creating.
Yeah.
All right. Anyway, I don't know if you can answer the gun store question, because I feel like the second thing you don't need to answer, but.
Yeah, I can answer the question about engaging with gun shops, and then Caitlin, I know we talked about this very question. So do you want to tackle that one about in terms of gun purchases and ownership?
Yes. Short answer is we don't have great data on it, but we're actively working on improving data collection around that.
Great, Bobby.
All right, this question may sound like it's out of left field, but I'm serious about this. In pediatric suicide analysis, is there any screening for parasite infections, particularly Toxoplasma gondii? Just curious if that's ever part of the autopsies.
That might have to be Dr. Bell.
I know, I was waiting to.
Yeah, sorry.
But I don't know if you have any data on that at all, Caitlin or Nick?
Not data that I have.
I do not, and but it might be a question for the chief medical examiner too.
Right.
As part of
Yeah.
Great. Again, Nick and Caitlin, this was extremely helpful, and I am so thankful that you came on moment's notice. So we appreciate your time, and I'm sure we'll be talking to you soon. So thank you.
Cool. Thank you so much. And I will, we do have some information about a past project engaging with gun shop owners. I will share that as a resource. And we are looking to do a new version of that project, hopefully in the next year. So
Great. Thank you.
everyone.
Terry, thank you for staying with us this whole time. I don't know if you submitted written testimony or not, but if you were introduce yourself for the record and then please share with us your experience and we may jump in with questions if that's okay.
Hi, everyone. Thank you so much for having me today. My name is Terry Lavley. I want to be very transparent. I just entered my 19th year of working for a designated mental health agency in Vermont. So I've spent my entire adult career working in mental health. But today I'm testifying on behalf of the American Foundation for Suicide Prevention in all of these. I just want to be very transparent. I have 4 pages of notes in front of me because I've been watching testimony over the last 2 days, and all of this, it hits home to me because it empowers me and excites me. But I'm a loss survivor. I lost my 18-year-old nephew 7 years ago to suicide, and actually tomorrow is the 20-year day of my own attempt of taking my own life. So I have both lived experience of attempting and loss survivor. So I come from this work from professional, personal, many different aspects of what we're talking about today. And I'm so grateful for all the work that we did on H740 last year that we got passed to move things forward with the new director's position, support for educations, different things that have been happening across the state of Vermont. But there's a ton to unpack today. And sorry about my 4 pages of notes. So my brain swirls all over the place. I try to keep my professional, my volunteer work separate, but it very much intersects as the agency I work for is a 988 Lifeline provider, and I have a lot of information on that. So I wanted to share with all of you because I feel like unless you live, work, and breathe this work of suicide awareness and prevention, it can be extremely confusing on the system of care and how all of these different areas impact each other. And I know that last year we did a lot of work to get the suicide prevention director position passed, which I'm so grateful that Chris Allen took that position. He's a super great ally to AFSP Vermont. So the goal is just really to empower that position to bring it all home and create this the system of care of like, how are we working together and what makes sense? So the areas in red are the underfunded or the asks of what we're doing, but it's not so much underfunded, but what really, really makes sense for Vermont. And there's been a lot of focus on the Suicide Fatality Review Committee that is in coordination with the data linkage process and also like educational offering, educational and training, 988, all of those things. So these things all work together. And I think with this new position of the state suicide prevention director, it's going to pull things together eventually. And there's so much great work that's happening through AFSP, Center for Health and Learning, the Vermont Suicide Prevention Center, NAMI, Pathways. There's all this great stuff happening, but how do we pull that together in a system of care is really the question. And when you're not embedded in this work and you don't understand, you're not like a boots on the ground, it's hard to understand how one component affects the other and where the priorities are. So this may be a familiar graphic to some of you last year because I got to testify last year. So thank you again for having me back again this year. Just a little bit of an update with like how the Suicide Fatality Review Committee is going to impact training and supports, education and trainings. And I want to spend a little bit of time on school systems. So the Fatality Review team and the data linkage process, Nick and Caitlin are awesome. They're great partners in data collection. Data is really what drives what we do in Vermont. And I don't think it's an either or. I think it's how can we work together? How can we link those two things together so the data linkage process can inform the fatality review committee of what's really going on to identify training opportunities, gaps in systems, marginalized populations, diversity, equity, and inclusion to move those things forward through our systems. So really, I just love hearing from everybody about how the different systems works. The Child Fatality Review Board is an awesome example of how we've made changes within our systems. So how can we mirror that for a Suicide Fatality Review Committee to coordinate with a data linkage system to make informed, educated decisions about how we move processes and procedures forward, which is all linked back to trainings and supports across Vermont. So education and training is, it's my love. That's what I do for my professional work. It's what I do through AFSP. It's really, really my love of everything, because the more knowledge and power we have, it's postvention, it's prevention, it is everything, because it's not a one person job or responsibility. It's wrapping the continuum of care around education and supports. So yes, designated agencies and SSAs can have training and supports, but if we don't give that to teachers, students, administrators in our school systems, we're not doing our due diligence of wrapping the continuum of care around it. So for the ask of the educational systems, we can mandate evidence-based practice trainings for our school staff, but we're not doing our job. We're not doing our due diligence of educating our youth about what their mental health is. We're not doing our due diligence about educating our parents and caretakers of those youth about what mental health is, what it feels like to struggle with your mental health, and how to wrap supports around that. So in my experience, both personally and professionally, wrapping a continuum of care around a school or a school system is vital. So it's not just mandating it for the teachers, and it's not just evidence-based practice, it's also evidence-informed practices, because there's a lot of great trainings that aren't evidence-based practice, but they're evidence-informed. And it should really be on each and every school home to say, this is what's going to work for us in our home. So we're going to mandate 3 hours a year or 3 hours every 3 years of suicide-based trainings. And we get to choose evidence-based or evidence-informed trainings that are going to really fit into what we do. I've had very great pleasure of working in our school systems in the Northeast Kingdom of, here's what we're doing for the littles, for pre-K through 4th grade, 5th grade through middle school and high school years, and really just hearing what they need as a school home and a school community, but not only working with the teachers and administrators, but the students and the parents and caretakers. So we're so focused on giving the teachers the tools, but if the students, parents, and caretakers don't have those same tools and education, we're doing a disservice to the continuum of care wrapping around that. And it's also upstream thinking, right? Like when we start at a younger age, when we start in pre-K, kindergarten, 1st, 2nd, 3rd, 4th grade, we're hitting those adolescents that aren't adolescents yet, of like, they're not experiencing those hormones and those high like mental health, emotional needs yet. We're educating them about what their mental health is. So when they get to an age where there are chemical things happening in their body and social, emotional things happening at school, they already know, right? They know, this is my plan. This is what I've created around myself. So I would like to see some more upstream educational thought process that is not just around evidence-based, but also evidence-informed trainings, because If we limit it to evidence-based, we are really putting handicaps on schools of their choice for their school communities and their school homes of what they choose for trainings, but not just for the teachers and administrators, the students and the parents and caretakers. So I'm going to just pause first get there around school-based stuff.
Any questions? Topper?
Thanks for your testimony. Has anybody had the idea that training for parents when their children are in school, training about what to look for and all that?
Yeah, and this is tough because I try to separate my personal and my professional hats, but they kind of intersect. But when professionally and personally, because I use a lot of AFSP trainings in my professional work, we do a school community-based approach. When we're working with the school system, we say first we're going to train the school staff and administrators. And then we're going to offer a parent caretaker evening around suicide awareness and prevention. And then we're going to offer it to the students. So when the students come home and they say, here's my mental health plan, or here's my safety plan, or here's what I know, the parents, caretakers, schools, and administrators are well equipped. So I think that when we're looking at this educational component of just limiting it to like school staff and administrators, we're doing a disservice to the whole system. It is our responsibility as a community, right? We need to wrap those supports around our youth and make it a comfortable conversation for them. So no matter who they go to, whether it's a parent, caretaker, school staff, or school administrator, they're comfortable in the conversations around mental health. And I think, AFSP has a great program. It's called More Than Sad, that really, it's for students and for parents and caretakers. There's two different modules and offering, and More Than Sad is like, I'm more than sad. I don't want to be here anymore. And it teaches parents and caretakers on how to address that with youth. And it teaches students, sorry, my office are a little loud. It teaches students on how to speak up and say, you know what, I'm a little bit more than sad today. I'm not just depressed or anxious. I just need more support with my mental health. And those are the kinds of offerings that we're currently doing in schools. And when we're talking about the system of care, which Chris was so great on presenting, like he's developing that. He's a very new director, and we appreciate, again, the support for H740 that got that position, pulling that all together of creating that continuum of care. But it can't be a blanket statement of saying, this is what you're going to do in your school. We need to empower the schools to identify what they need within their systems, because every school community is extremely different from the next. I got to tell you, I've worked with Sheffield, Vermont. Has anybody ever been to Sheffield?
Couple people here.
Yeah. And have you been to the St. Johnsbury or North Country schools?
Yeah.
Right?
Yeah.
They're very different feelings and communities. And so we need to empower Sheffield to say, what can we do for you, rather than this is what we're going to do for you, and wrap supports around communities where they're at, rather than saying this is what we're mandating on you. And also evidence-based and evidence-informed, or if we're limiting trainings for schools for evidence-based, then we are putting a handicap on schools, because there's great trainings that are evidence-informed as well.
I think there was a follow-up there, Topper.
Well, I think I heard you say that currently this is going on in schools.
Yeah.
Specifically talking to parents.
But is it universal across all school districts?
I'm not sure So again, I just want to be transparent. My hat's crossed. I work in the Northeast Kingdom, Caledonia and Essex, Orleans County. I know it's happening in our school districts. We offer parents' nights. We offer monthly community trainings. We are in the schools. We're offering the pre-K through 12 trainings, even beyond. We're at the college doing those trainings. But I feel like some universal regulations could be beneficial, but not limiting it to this is what you have to do, but expanding, looking at the system of a whole. And when we're thinking about that of like, what does that look like for a school? We were talking about like school-based policies and procedures around postvention, prevention, policies and procedures. The American Foundation for Suicide Prevention has that. We have guidelines already that we have been providing to schools across the state of Vermont as they're asking for it. And they can view them and adopt these policies and procedures as they feel fit for their own school homes. It's not a prescribed thing. It's like, here are our recommendations and please adopt them as you feel fit for your home, because we do fully recognize every school community is different.
Okay, I just, maybe I don't understand English. I'm really, you say you're offering this kind of informational training. Is it happening? Is it actually happening? Are people coming to a place and listening? Do you get very few people? I'm trying to understand exactly what you mean by offering.
Yes. So both personally and professionally offering, and I know the school systems are doing their due diligence. I have a 6th grader at the St. Johnsbury School, and 3 weeks ago, John Halligan, who lost his son Ryan to cyberbullying, they didn't offer. All 6th, 7th, and 8th graders participated in a school offering during the day around cyberbullying and suicide awareness. And then they offered a parents' night, which I went to because I'm invested in this. So school systems are organically doing this on their own and without a mandate, right? Like without legislative saying, you have to do this, offering guidelines, support, and best practices through this process will help move that forward. So I feel like educators, teachers, administrators are invested in this process. So we, in my professional work and through AFSP, have been offering, putting out there. We also have, through AFSP, we have a contract with the Vermont Principals Association where we're going to be doing more tabling, community outreaching trainings for staff and administrators. So they're proactively already taking the approach through the Agency on Education on making sure that suicide awareness and prevention is available in their schools.
Thank you.
Terry, can you, I know you have 4 pages of notes, so I don't want to take you off course, but we had a lot of conversation yesterday on 988, and my understanding is you have been connected to the 988 system. So can you just give us some information on that?
Yeah, so professional hat, which I can't testify with a professional hat, but I'm going to just give my lived experience. I onboarded 988 through my professional work at our agency, and we are coming up on our 3-year anniversary of that. I did hear some testimony yesterday about how 100% of screeners, 100% of callers are screened, but only 78% are safety planned. And I just want to give some clarifying information on that. 78 of individuals that call have safety plans because they present some kind of imminent risk. whether it's they have a plan but no means, or they have means and no plan. And the other 22% didn't require safety planning because their level of risk didn't reach that level of heightened awareness. So that was more like resource coordination and follow-up calls. Like, we're going to check in with you to make sure you get connected to the resources. Not everyone that calls 988 requires a safety plan. Sometimes it's like, I'm lonely, I'm lost, I'm disconnected, I need somebody to talk to that's not in my social circle. So there's a lot of 988 data out there. There's a very strong coalition in Vermont, our 988 coalition. We're going to actually meet tomorrow to share like training resources, data collection, all of that information. But there's a lot of logistics around data collection, and 988 is a fabulous resource in Vermont, not just for the adult population, but we're finding a higher use in our youth population because we're promoting it more. We're putting 988 tear off in like bathroom stalls in schools so kiddos can chat and text, which weirdly is kiddos' form of communication.
There was some discussion yesterday about 988 and how we know it's helping. Do you have any thoughts on what you can share with us on, is it helping Vermonters? And, because we don't really collect information, right? It's anonymous. We see the numbers going up, but what does that really mean? Do you have any thoughts on that?
Yeah, so how is it helping Vermonters, right? The numbers are going up. More people are calling, more people are chatting and texting from Vermont. So I don't think there's 988 just rolled out on July 16th of last year, and there's not solid data on how it's helping. So I'd like to see the impact of data collection on how we've reduced emergency room or designated agency intervention because we were able to give that immediate response from 988. And a lot of times callers are just looking for a connection outside of their social circles, that peer support of, you don't know what's going on with me and I just need a safe place to go and to talk. And I think a lot of that goes back to our highly trained, our highly educated 988 workforce. And it's a lot of peer support work too, of sitting comfortably in that uncomfortable conversation. I might not know what you're going through, but I'm here with you right now and I'm here to listen. So I don't think have a good grasp on the impact, but I do know 988 calls, chat, and text are rising, which is great because it's diverting from emergency room, police intervention, ambulance, like all of those different things. But I think it's going to take us a little bit of time to gather more information around collective impact as a system, especially because post-pandemic mental health issues have increased. And we are seeing higher rises in that we've never seen before. So we don't really have a good gauge on how the increase of mental health issues has impacted 988 with the decrease of other services like mental health treatment facilities, emergency departments. So that wasn't really a super direct answer.
No, that was helpful. Yeah, no, that was helpful. I think it is difficult to assess the impact of a line like that. And like you said, it is fairly new. So we'll try to figure something out, as I'm sure everyone within Department of Mental Health is as well.
Yeah, and I think of if we can prevent one caller from going to the emergency department and clogging up our mental health systems by safety planning with them over the phone and doing a little bit of follow-up, that's a win, right? It's a win for the person of not entering that more invasive level of services. And
I agree.
Yeah, because emergency rooms, I love our physical health providers, but it's not a place for people in mental health crises to land for treatment. They oftentimes get stuck there for days and days and days, waiting for inpatient or more restrictive. So if we can do more organic planning around that.
Great. Any questions from anyone? Alan?
If a school is interested in your services, how do they go about reaching you, and what would you suggest they do on the onset?
So in the Northeast Kingdom, everybody knows me. And they know that that's my paid position, but this is where I think that our Zero Suicide Initiative through the Center for Health and Learning and supporting all the designated agencies and SSAs across Vermont. Like, how do we create a continuum of care that's not just like assessment, treatment, but it's also education and training? And how do we spread this across Vermont? So through the American Foundation for Suicide Prevention, we are a volunteer organization. And most of the time, the individuals that volunteer for AFSP are lost or attempt survivors. And so we get trained to deliver these trainings, which is absolutely the best way to do it, because that's that peer support. When you have a peer delivering a training because they have their lived experience, that's great, right? Because the peer can relate to, like, I've lost or I've attempted, and this is why I'm doing this work. So that's why we really, really need to push the expansion of zero suicide and designated and SSAs. Education and training should not just be for the designated agencies. When we think about service providers, teachers, administrators, primary care, emergency department, hospitals, council on aging, our housing agencies, education and training is a community responsibility. And when we start wrapping that support around individuals that are community-based service providers and community members, we're creating a community of care. So not one person is responsible for it, but together we're embedded in this work.
That help, Alan?
Yes, yep. I only live 30 miles from her.
Oh, really?
That's sharing. Sorry.
No, that's great. And the graphic was very helpful. Thank you. Other questions for Terry? Terry, are there things that you want to leave us with? Important nuggets that we should know?
I just want to say that when you're not working and embedded in this work professionally or volunteer, it's hard to wrap your mind around how all these systems work together. And it's very, very exciting to have Chris on board as our suicide prevention director. Caitlin and Nick, like data is not my thing, but I look at the data and I make so I'm like, what we're going to do to roll things out professionally and through AFSP. So there's really this system of care that is being developed in Vermont, and it's very exciting to watch this roll out, but we have a lot of work to do. And it's not just AFSP and CHL that are doing the work. We have many, many partners, Pathways Vermont, NAMI, there's many other organizations. And through Chris's leadership, through that director's position, we're going to be pulling this all together. And postvention trainings, I know there was robust dialogue yesterday around postvention. Please keep in mind that postvention is prevention. And 3.8% of an individual that has experienced a suicidal loss is 3.8% more likely to attempt. So as we're thinking about postvention, it is also a very preventative measure. And when you think about mandating things for schools who are already super overburdened, right? Like, thank you, educators, for doing everything you do for our kids. But think about the whole system, not just for the teachers and administrators, but for the parents and students, because we need to create that community. We need to bring it full circle around, because designated agencies, SSAs, they're not fully responsible. We need to create a community of awareness and training. And we need to think upstream of how we're starting younger for our kiddos. just making it okay to have mental health, because we're all human and we all have mental health.
Right, exactly, including our children. Thank you, Terry. And I also want to thank you because you were also a last minute invite this morning. I woke up at very early with all sorts of ideas. So thank you for coming in, for all the work you're doing in Vermont. And we have your contact information now. We may reach out again as we continue our discussions through the year. So thank you very much. Appreciate it.
Please let us know if there's any information or guidelines or anything we can support with, or questions. We're happy to help. And, you know, AFSP Vermont has been healing for me and my loss, and also acknowledging my attempt almost 30 years ago. And I'm proud to do this work. It's hard and difficult work, but I lean into it happily. And I'm very thankful for all of you that have
Great. We're glad you're here today. Thank you.
Terry.
So I want us to take a 10-minute break because I think we need to stretch, but I do want to come back out and have a committee discussion for about half an hour, come back and